All right. Well, I have been really looking forward to this interview today. We are going to be discussing a vitamin D quality improvement project that was initiated at Vibra Hospital in North Dakota. And today I am talking with Bonnie Vangerud and Kristen Schimmel, who both work at the hospital and who decided to take it on themselves to take action with the information they were learning about vitamin D, the importance of vitamin D, but most impressively, what to do about it with their patient population. So, ladies, if you could please briefly introduce yourselves and the hospital and patient population that you work with, that would be fantastic.
Okay, my name is Bonnie Vangerud. I'm the Chief Clinical Officer at Vibra Hospital in Fargo, and we are a 31-bed hospital that takes care of long-term acute care patients. And so oftentimes when people hear long-term, they think skilled nursing, but we are not a skilled nursing facility. We are a hospital facility where we have 24-hour nursing and physician care coverage. And our average length of stay for our patients is 25 to 30 days. Some of our patients stay much longer, and some of our patients stay shorter, of course. My name is Kristen Schimmel. I am the Professional Development Coordinator here at Vibra Hospital Fargo. I help coordinate with patient care education needs as well as staff education.
Great. Well, thank you both for being here today. Would one of you please just enlighten us as to what got you interested in vitamin D and motivated enough to implement this project at your hospital?
We met with Dr. Beth Sanford, and she was giving education to us as well as our staff about the importance of vitamin D and how it can affect our lives. And so it's built into covering about how it could improve our patient outcomes as well. It was at that point that we thought it would be a good idea and wise if we included our patient population. So we had further conversations with others in pharmacy as well as our medical director. And Kristen, do you have more to add? And really, just all the evidence that Dr. Beth Sanford was able to provide us really showed that we need to be our patients' advocates and want the best care for our patients. All the research has indicated all the benefits that have come from vitamin D. I really wanted to give our patient population that chance.
Got it. Got it. Great. And was anything being done about vitamin D, or how was vitamin D being addressed in your patients at that time or prior to the project?
It really wasn't a main focus of patient care. Some of our patients came to us. They come from another facility. Some do come on vitamin D or taking vitamin D, but we really didn't modify that dose or monitor their serum levels until after we started our improvement project.
Okay. And then can you just briefly break down what was the protocol that you implemented after learning about vitamin D from Dr. Sanford, who I just wanted to say I'm sorry she couldn't be here today, but we'll have to do another interview with Dr. Sanford. But yes, so what were some of what was part of the protocol that you implemented?
Upon admission, we do a serum blood draw, included with all of their other lab work that we're drawing to check out what their vitamin D level is. Our dietitian then takes that serum level and plugs it into the GrassrootsHealth calculator, that online tool, to establish their bolus dose as well as a maintenance dose. So from that value, she discusses with the physician, who can then in turn order the vitamin D that is needed. We do follow-up levels at either day 25 or upon discharge if they're discharging more at that 3-month mark. But we do want to catch them before they leave here, so that's why we implemented that 25-day recheck. At 3 months, we recheck their vitamin D level, and we can adjust accordingly if it's a little bit higher than the calculator is aiming towards, or if it's still on that lower side. We do that monitored lab value.
Okay, and just to clarify, that's the 25 OH vitamin D level.
Yeah. And we also look at exclusion criteria. So we built some exclusion criteria into that. For example, some of our the dialysis patients, granuloma patients, sarcoidosis and hypercalcemic patients. We do not do the vitamin D with them.
Okay. And since we're talking about this, were there any other challenges or any kind of pushback or questions that were posed to you when you were initially discussing the project with the hospital administrators, with the other employees, or did you receive any kind of pushback, or was there any amount of fear around starting this project that you had to address?
would say fear. I think a lot of questions. Just for historically, this is a larger amount of vitamin D that our providers have seen, our nurses have seen, as well as pharmacy. So I think just that awareness and knowledge that the studies and have been around for years and the safe amount. So I would say it's not really a fear, but there were a lot of questions. We did provide education through in-services, multiple class with our physicians. And then also when patients are being discharged, that's the population that we, I would say, would have the most difficulty with, just because they are not physicians that actually work at Vibra. We they're the patient physicians outside of the hospital, and so we developed a pamphlet that the patient takes with them, letting them know what their discharging vitamin D level was and what the medication dosage that they were on. So that's the most difficult part, is that ongoing education outside of our control.
Right. So it sounds like, just to kind of summarize the protocol that you implemented, measuring baseline vitamin D levels at admission. And correct me if I'm wrong, you used a target vitamin D level of 50 nanograms per milliliter. And using the calculator on the Grassroots Health website, you were able to be given an estimated dose, loading dose to implement for a certain number of days, followed by a maintenance dose, which is a lower dose. And then you rechecked after 3 months, and then again until achieving that 50 nanograms per milliliter. Or can you just clarify a little bit in terms of, what were some of the vitamin D doses that you were giving? And, did you stick with a dose once they reached the 50, continue to adjust? Just a little additional direction here, if you don't mind.
Do you want to take that, or do you want me to? Yeah. So we would do their vitamin D level draw, like Kristen said, at 25 days or at 3 months. And then we also did reassess once they were on their basically baseline dosage of vitamin D, if they were still here at 90 days, just to make sure that the dosage was still good for them. And then, yes, we would adjust accordingly, and with the physician involvement.
Mm-hmm.
We did see some higher amounts, some of those 50,000 units loading dose to some of our patients. To pull up data. Right.
Okay, so you were aiming for a level of 50. And some of those patients required up to 50,000 IU loading doses.
Yes, most of them do on admission, because I will tell you, we really want our patients to be between 40 and 60. And I will tell you that most of our patients, when we get them, they're less than 20.
Mm-hmm.
And some as low as undetectable.
Wow.
You can only imagine our patients, we're a long-term acute care hospital. So they come from the short-term acutes, and typically they're in the short-term acutes, 2 to 4 weeks prior to coming to us. In North Dakota, the only time you're going to get vitamin D levels is typically between the month of May to September, on the hours of the day, 10 a.m. till 2 p.m. Okay. And so if people aren't taking that, any vitamin D orally, or they're not, if they're working, they're not necessarily getting that vitamin D.
Right.
And so many of our patients are subtherapeutic with their vitamin D levels, and vitamin D is so good for many things, pain control, decreasing infection, decreasing inflammation, decreasing your cancer risk, and that's just to name a few. Kristen just pulled up something. Yeah, to answer your question, majority of our patients, just looking back to these past few months, so from like November of that last year up until now, it looks like almost every single patient that we have implemented this protocol on has required that 50,000 unit loading dose.
Wow. And can you see their starting vitamin D level at admission as well?
Did you want to know the values?
I'm just curious. We're also talking because we're nearing the end of winter and you're up in North Dakota. And so, as you said, if somebody's not taking vitamin D, they're very likely deficient, at least below 20. But you're also receiving patients from other hospitals, and they've already been in the hospital. So not only are they not going outside at all, who knows if the hospital is giving them vitamin D, but also their bodies are in some kind of physical situation where they're fighting some kind of infection or their immune, their body is most likely using up a lot more vitamin D because of the state they're in. And so it's a curiosity, and we can always go back and look at some of the data that has been presented previously, but it is a curiosity around, what the average vitamin D level is right now of those folks that you're receiving.
What I'm seeing is our average is below 20. Like we have some that are 6. I see some that are 12, 9, 17, 18. I do see years. One was 45.
And some of these patients were being received from other hospitals that were actually giving vitamin D. Is that correct?
Yes, and I don't know the rhyme or reason behind when patients are receiving vitamin D at other hospitals. That I do not know.
Okay.
Because they don't all.
Go ahead.
Oh, I was done. We don't know the rhyme or reason why some patients come on vitamin D and why some don't. We don't know that.
Okay.
And what I'm seeing in our spreadsheet is that depending on their vitamin D level, and of course the grassroots calculator, that will tell you how much of a bolus or a starting dose that the person gets. And so some of our patients, like for example, patient that had a vitamin D level of 6 got 50,000 IUs every 48 hours times 12 doses.
And that's what it took to get her where?
Let's see here. And that would be followed with a loading or a maintenance dose of 10,000. Yep. Can you watch that? Yep. And let's see here. This was when the patient discharged, the patient was at a level of 46.
Great. So we can assume that what you're saying in terms of your patient levels coming in is what your hospital has been receiving for many years. And it's probably representative of the overall situation in North Dakota, especially within the hospital systems. Now, how long have you been running this vitamin D project?
Since March of 2023.
Okay, all right. And what have your initial observations been in terms of health outcomes since you started running the project?
Overall, we do have a wound nurse that has been collecting data too, and it's hard to determine exactly if it's vitamin D, but it's hard to say that it's not because she has seen such great improvement with wound care and their healing properties with that. That's one example. We've had a lot of patient outcomes that seem to drastically improve after the implementation of vitamin D. Are you wanting specifics like patient scenarios?
Well, a couple of stories would be great. And then once you kind of go through some of those, another comparison between how, the outcomes prior to initiating this vitamin D project and then the observations that you've noticed since.
I can talk about our CAUTIs and CLABSIs. So, of course, none of us want to have any CAUTIs and CLABSIs. In 2023, and I don't have, hold on for one moment here.
Sure. And while you're doing that, what is CAUTI and what was the other one?
CLABSIs. I will explain that just one moment. I'm just
Perfect.
looking for, I just have this document pulled up. I apologize. I can just speak to that. So a CAUTI represents a catheter-associated urinary tract infection. So that would be if they have a Foley catheter indwelling. And a CLABSI is a central line infection. So that would be like a central line, a PICC line. So between the two different infections from a central line versus a Foley catheter.
And what did you notice with those?
Okay, so for example, we've been trending data. And so from 2022, okay, I'll give you some data from 2022. For CLABSIs, we had 2 central line infections in 2022. In 2023, we had 4, but in 2024, we had 0. And for CAUTIs, those are the catheter-associated urinary tract infections, we had 5. We had in 2022. In 2023, we had 0. And in 2024, we had 1. So there's a couple of things involved. Of course, as everyone is looking at how to rid our patients of CAUTIs and CLABSIs, there's the new products that have come out and new ideas of what we can do to help prevent. And so, of course, if you don't have a central line or you don't have a PICC line, you're not going to have an infection. And so we do try and remove those as quickly as possible. But a lot of our patients are on long-term antibiotics, and so they require some of that longer term. Of course, we do try midlines as much as we possibly can as well. But to go from typically, we've been running anywhere from 2 to 3 is what our average has been for a CLABSI since 2020 to 0 in 2024. I think that's pretty remarkable. It was also recognized by the North Dakota Health and Human Services Department about our reduced rate of infection. And CAUTIs, those are the catheter-associated urinary tract infections. Our average for that since 2020 was about 4. We had 0 in 2023 and 1 in 2024. So again, there's new products out there that we certainly have been utilizing for our patients to help reduce CAUTIs. But I can't say that it's all due to the new products and due to the removal of lines. And I can't say that it's all due to vitamin D, but I don't think by having the vitamin D but I do think by having the vitamin D on board, it certainly doesn't hurt, and it possibly might be helping our patients.
Right. Yeah. And what are some other possible ways that the vitamin D has been helping your patients?
We have seen patients that have had traumatic brain injuries when they have come into our hospital. We had a 20-year-old who there was no focus, no follow. She had great family supports, but she really was not alert, awake, interactive. She was on the ventilator when she came to us, given a pretty poor prognosis, and saying that she would never wake up or get off the ventilator. Mm-hmm. And I can't remember if it was 6 weeks in, but she woke up. She was able to be in the hallway in the wheelchair, was having conversations, meaningful conversations, and went on to the next level of care for rehab. And I mean, I'm sure she's out in the community as a functioning a functioning adult as we speak.
Wow, that's amazing.
From going from not being given a good prognosis to that, and we've seen that a number of times in the last couple of years.
All while implementing this protocol for almost all of your
Yes,
patients, including these ones that we're talking about.
that's correct.
That's
Yep.
fantastic. And in the meantime, have you observed any cases of toxicity or negative effects attributed to the vitamin D?
None. No, we've had no toxicities.
And how are you tracking that?
Again, by doing our lab values, at 25 days upon discharge or 3 months, or excuse me, 90 days. So we do track it, and dose accordingly from what the level was.
Right. So would you agree with this statement that Dr. Patrick McCullough in Ohio, I believe he is, he says this quite often. When you're using vitamin D at these levels, nothing bad happens, only good things happen. I love when he says that. Would you agree that that's what you've seen?
We haven't seen any negative outcomes due to vitamin D.
Yeah.
I can say with 100% accuracy that our infection rates are lower. I can see that our outcomes are trending in a positive direction. Again, there's other things that we've implemented along with vitamin D, so I can't say it's only the vitamin D, but a package deal, I think, has proven positive for our patients. And that's what we're here. That's what we do. We want to have a positive outcome for our patient population.
Right, right. What have you learned along the way since you've implemented this project? How, have you noticed in any ways that it could be improved? Are there any areas that might need additional support in terms of the education of the health practitioners and the patients? Or what would your feedback be to those who either helped you implement this project or who would like to help others implement similar projects?
I'm grateful that we're able to, we've seen it improve our patient outcomes, and I think we've been able to provide a lot of awareness just amongst our staff. They're bringing it home to their families. I brought it home to my family. I mean, from a personal level or personal stance, I wouldn't have known this knowledge had it not been from Dr. Beth Sanford bringing us this information and us being able to implement it and see the outcome. I think it's going to be kind of a continuing need for education because we still have outline pharmacies calling their physician, wondering or questioning about this outrageously high dose. So I think it's gonna need to continue a lot. I would love to be able to give more education within hospitals around this area just to implement it prior to our patients receiving it. Education I don't think will be ending anytime soon.
Yeah, yeah. Do you have any personal stories to share, if you don't mind, about how vitamin D might have affected your own health?
Well, my daughter, for example, she's a 14-year-old, very active, outside in the summer months, of course. It's winter now, so that's not really an option, but she had been struggling with headaches pretty frequently. So I did bring her in at the beginning of February. So this is still pretty new, but her vitamin D level was 19. So severely low. The doctor that we see prescribed a very low dose in comparison to what I did use the GrassrootsHealth calculator and utilize that instead. We did a loading dose for 3 days, and now she's on a maintenance dose according to the calculator, and she hasn't had a headache since beginning of February.
Wow.
I don't know if it's just by chance, but I don't know. It seems like it has made a difference. And we have a lot of international nurses that work here at Vibra. Thank goodness for all of them. But you can imagine coming from the Philippines or from Africa where you're getting a lot of sunshine during the day, and then coming to Fargo, North Dakota. And so, where you're not getting much. And then working as a nurse, of course, you're indoors, either sleeping or working for 12 hours. So you're not out in the sun during those moments either. And so, just bringing the awareness to our staff as well, like Kristen said, to make sure that they are taking good care of themselves. And I think people feel a difference. I do anyway. I do feel a difference when I take my vitamin D and my mental health versus when I don't. I can
Mhm.
tell my level is low or not.
Yeah. Yeah, it's pretty amazing. It is just a vitamin, but it's also a really important one. And the fact that so many people are not getting enough, where just deficiency is so prevalent, it does affect every tissue in our body and both our mental and physical health. And so this is a really easy, safe, inexpensive way to address our overall health is by getting our vitamin D levels up to where they're meant to be. If we were getting plentiful sunshine, but I'm really grateful that you both took this project on, and I really hope that other hospitals and other groups consider doing the same type of project. So if you wouldn't mind, what would you say if you were giving an elevator pitch or something to encourage other hospitals or other groups to implement a vitamin D project like this? What would you say?
Vitamin D is very inexpensive, and its evidence has shown that it has proven outcomes. So why wouldn't you want to do that for your patients? Give them every possible chance of recovery um, and resistance of infection. Um, it's easy and it's not harmful. Um, why wouldn't you want to do it? It's like the right thing. And not everything has to cost a lot of money.
Or be so complicated?
Right. Yeah,
Yeah.
it's very easy. We have our dietitian is very involved with this, so she sees the lab values that come back. She puts it into the calculator as the recommended dosage, which is brought to our physicians, and our physicians order accordingly. And they've been phenomenal in all of this, very much on board. Um, so we're grateful for our entire team.
Yeah, and that's really a key piece to a project like this because we've been involved in other projects, and the education of the staff, of the doctors, of the nurses, if they're not aware of why they're doing this, it's more likely that they won't. And so that education is key. Before we close, are there any other key points, any other observations, any other stories that either of you would like to share?
The stories are very similar to the one that Bonnie spoke to. We've seen the drastic difference with their brain injury patient or the patients that have come to us with the brain injuries. We see them able to discharge to a lower level of care than otherwise or told otherwise. So those are the most significant ones, but they're all very similar in the same story that they come, but it's when they do come to us as an admit that they don't have a whole lot of interaction, unable to verbalize, maybe still on the ventilator. Great outcomes where they are able to essentially wake up and start talking to their loved one. Yes, and Kristen and I have both worked. We both come from the ICU setting, and sometimes when we see these patients coming in, we're like, "What in the world?" Yeah. But we see just dramatic recovery. And when I say dramatic recovery, like I would say 90% of our patients have recovered to a meaningful recovery.
Wow. That I
Would you say 90%? Yeah.
You guys and Beth, Dr. Sanford, you are making a difference. And I appreciate each of you. I just really want other people to know they can make this kind of a difference too. And so they can reach out to us at Grassroots Health. My email, Jen, at grassrootshealth.org. And I'm sure if anybody has questions for anybody at Vibra, I can direct them to Bonnie. Or if anybody has questions for Dr. Sanford, we are all interested in implementing these safe and easy protocols with vitamin D to help patients anywhere possible. So I think with that, we can go ahead and close this interview. Again, I really appreciate your time, and more so, I applaud you for taking this step and seeing the research and asking yourselves what action is necessary for me to take this vitamin D information, to take the research and create some kind of active protocol within my patient setting so that I can make a better difference for them. And I really applaud you both and everybody involved at Vibra.
We'd be happy to take emails or calls if they come through. So
All right. Well,
thank you for this.
Of course. Thank you again, ladies.